Aloha, my name is John Oliver, and I'm humbly here today as the project director for the Ohana Center of Excellence and to introduce our featured speaker. But before I do, I would first like to share a little information on our Center of Excellence. Funded by a grant of the Substance Abuse Mental Health Services Administration, the Ohana Center of Excellence is a partnership between the state of Hawaii's Department of Health, Papa'ololakahi, San Jose State University, and California State University East Bay. We provide training and technical assistance for those working in the fields of substance use, behavioral, and mental health to better serve the needs of the Asian American, Native Hawaiian, and Pacific Islander communities through culturally responsive care. So what we aim to do here at the Center of Excellence is we have a resource directory where we have compiled cultural and community-based organizations and behavioral health resources that serve AA and HPI communities. And those are communities from the US APIs, across Hawaii, the continental US, and all the way to Puerto Rico and the US Virgin Islands. We offer real-time and on-demand learning opportunities, and these include multilingual materials and archived webinars with vocal interpretation in several languages in addition to English. And we also offer tailored technical assistance and available office hours to get one-on-one assistance. And lastly, we are currently forming national and regional steering committees made up of behavioral health providers, community-based organizations serving AA and HPI communities, and AA and HPI individuals themselves with lived experience. And coming soon, we will have data to help with research, downloadable resources, a community corner, and various toolkits. So that brings us to why we're here today. So the title of our webinar is The Importance of Disaggregated Asian American, Native Hawaiian, and Pacific Islander Race and Ethnicity Data. And the reason why the Center of Excellence is focusing on this has to do with our data that we currently have. And recent national data shows that 76% of Asian Americans, Native Hawaiians, and Pacific Islanders living with any mental illness, and 93% that have substance use concerns do not receive treatment currently. So disaggregating Asian Americans, Native Hawaiians, and Pacific Islanders is critical to better understanding the underlying behavioral health disparities, and in turn, inform behavioral health interventions and guide cultural competency training. So with that, let me introduce our speaker today, Dr. Kekoa Taparra, and he is a radiation oncology resident physician at Stanford Health Care. So I will turn it over now to you, Kekoa.
All right. Mahalo, John, for that very generous introduction. So yeah, aloha, everyone. For those of you who haven't met, my name is Kekoa. I am a resident at Stanford, and I'm very excited to be here today to talk about this very important topic of data disaggregation for this Asian American, Native Hawaiian, and other Pacific Islander population. I'd like to thank also the Ohana Center of Excellence and the Hawaii State Department of Health for allowing me to be here today. These are my disclosures. I wanted to also mention that I will be speaking from my own lived experiences today as a Pacific Islander, specifically a Native Hawaiian from both my mom and my dad's lineages, but I cannot speak for the Lahui at large, so I'll be speaking from my own experiences. I wanted to start the talk just with land acknowledgement. So I am again Kanaka Oiwi, whose ancestors come from the Aina of Maui and Oahu. I honor my lineages of Kekaulike, Koli'i, U'uma, Aki, and Akana. I acknowledge this Aina as a part of our grandmother, Papa Hanaumoku. I recognize it's my kuleana to Aloha Aina, and I invite you to join me in this land acknowledgement. I acknowledge our queen abdicated her throne to protect her people from bloodshed at the time, and I recognize that Hawaii remains an illegally occupied state of America. I mahalo my ancestors who shaped Hawaii in these sustainable ways that allow us to enjoy these gifts today. And I ask that we respect the space and advocate for equity among Asian Americans as well as Native Hawaiian and other Pacific Islanders. And with that, I'd just like to do a little bit deeper dive in terms of, where I'm from, born and raised here, where I am located currently in Mililani, Oahu, Hawaii. These are my parents, both, again, Native Hawaiians. I went to the Kamehameha Schools, which many of us know is founded by Princess Bernice Bohe Bishop in 1887 for Native Hawaiian youth in a time where we were truly undergoing on the brink of extinction. And she wanted to really ensure that her language, culture, traditions were perpetuated among Native Hawaiians, and at the same time was also going to be educating students in the Western ways. I then went to the East Coast for college and met a lot of really great professors who then encouraged me to go to graduate school. So I went to Johns Hopkins School of Medicine. I was inspired by the stories of my Native Hawaiian ohana, who 10 of them had diagnoses of cancer, various types of cancer, and all but one, at least today, I've actually passed away, unfortunately. So from a young age, I saw how cancer really impacted members of our community among the Native Hawaiian community. And so while at Johns Hopkins, I focused on sugar metabolism at the bench, working on models of cancer in the lab. And that's where I met my PhD advisor, Dr. Phu Tran. He was truly the first physician I'd ever been able to talk to in my life. He was the first to bring me into the clinic, and I watched him talk to patients and say the words like, "Let's go for cure." And he really inspired me to go into medicine, encouraged me to do so. And so that's why I went to Mayo Clinic out in Rochester, Minnesota, where they gave me the opportunity to actually come back home to Waimanalo Health Center in Queens, West Oahu, to see how physicians here are taking care of our communities. And so now, again, I am a resident physician at Stanford Health Care in the Department of Radiation Oncology, where I train to treat a number of different diseases, specifically focusing in a variety of different cancers. So now we'll go into the agenda for today. I'll first talk a little bit about Pacific Islander backgrounds, which should be a quick review for many of us online today. Then I'll specifically focus a little bit more about Hawaii's history, and then dive a little bit more into Pacific Islander health in general. Then we'll again talk about this concept of data disaggregation and how it relates to concepts of structural racism. And then finally, we'll kind of talk about some examples of data disaggregation, how it's important. So first, again, talking about Pacific Islanders, many of us here today from, U.S. affiliated Pacific Islanders, islands out to, here in Hawaii, we know this information, but for those maybe tuning in and not familiar, I always start off with this example of, why in the Pacific we're often forgotten. And I think it's truly because even if you look at a world map just by Googling images, you'll see that, and when we think about the world, we really think about it's a very America, Africa, European-centric view of the world. And so my task is always in these talks to help us kind of shift the map a little bit, so help us reframe the Pacific and really focus in on this area so that we can identify the health disparities in particular as it pertains especially to data disaggregation. So as many of us will recognize, this is Asia. And I always show this little animation here because it really highlights the vast distances really when we think about where the Pacific Islands are. And these are the homes to the Pacific Islanders. Each one of these islands can be thought about in these three ethnogeographic regions that we talk about a lot, Micronesia, Melanesia, and Polynesia. You'll see out here in Asia, islands like Japan, Philippines, Malaysia, Indonesia. While they're Pacific Islands, while they're islands in the Pacific, they are part of Asia. So that's not exactly what we're talking about when we're talking about Pacific Islands and Pacific Islanders. And I always make that distinction. And so, for example, in Micronesia, where we have some, viewers today, graciously being here today. These include islands such as Guam, the Northern Mariana Islands, and Marshall Islands, as well as the federal states of Micronesia, and Melanesia, islands like Papua and Fiji, and then Polynesia, which most people on the continent will recognize, including Aotearoa or New Zealand, up to Hawaii, as well as French Polynesia, which includes islands like Tahiti. So each of these islands, while very, heterogeneous, we do have a deeply rooted history in oceanic voyaging heritage that was, continued through our cousins in Micronesia, like Master Navigator Mao, and then continued on through kind of present day Polynesians such as Nainoa Thompson. And these are skilled navigators, again, who our ancestors were skilled navigators who used nothing but the ocean, the stars, true nature, and they were, real true scientists as they've made these deep observations over many, many hundreds of years to then inform their practice of how to sail throughout the Pacific. And so this is a recent publication that my lab and all of these authors were actually either Chamorro or Yapi, so Micronesian. This is a study, this is a publication, a review that we published recently on cancer disparities in Micronesia. But I'm showing this as an example of, just when we look at Micronesia alone, this broad region, and we think about, 3,000 miles. So this black line is representing this white line here in this figure. It's truly an enormous feat that our ancestors were able to do in order to kind of navigate intentionally throughout these islands. And we respect this knowledge because many Westerners previously had thought that, Pacific Islanders had kind of just fell onto these islands through storms and such, but these were masterfully and intentionally navigated spaces that our ancestors navigated through. And so each one of these islands have their own indigenous people, including the Kanaka Oiwi or Kanaka Maoli here in Hawaii, so the Native Hawaiians. And when we look at the US Census, for example, here in the United States, Native Hawaiians obviously make up the bulk of the Pacific Islanders, but that's followed by Samoans, Chamorro, Tongan, Fijians, as well as Micronesians and Marshallese as well. And so we think about our group together as the Native Hawaiians and other Pacific Islanders. So in summary of this short first section, Native Hawaiians and other Pacific Islanders were truly a diverse and culturally rich population, but sharing this deep history of oceanic voyaging heritage. So when we think about now Hawaii history, kind of zooming in a little bit more, I just talk about this timeline since, the Hawaii State Department of Health is located here, and I'm kind of representing this region for right now. When we think about the first voyages, let's say somewhere around 500 AD or so, and it wasn't really until over 1,000, 1,500 years later when first Western contact came with Captain Cook. A lot of people may not recognize, but the Hawaiian Kingdom was actually established in 1810 under the first rule of King Kamehameha I. He was the first to kind of basically have various battles throughout the islands in our Hawaiian Islands, and then reunite all of the islands under one kingdom again in 1810. A lot of folks might not realize that the Hawaiian Kingdom actually gained independent sovereignty, recognized with international treaties with Great Britain and France. These were, diplomatic recognition. And so in 1843, that's when this occurred, with Lā Ku'oko'a being our kind of Independence Day that a lot of people might not know about. And so what we do, many of us do recognize, is that in 1893, a group of people, predominantly white businessmen in our islands, then came to Iolani Palace, held our queen in Iolani Palace, and kind of in violation of international humanitarian law, kind of forced the abdication of the throne of the Hawaiian Kingdom. And so this was Queen Liliuokalani's words. She says, "By the grace of God and under the Constitution of the Hawaiian Kingdom, I, Queen, do hereby solemnly protest against any and all acts done against myself and the Hawaiian Kingdom." So she clearly was protesting the overthrow, and she continues on and says, "To avoid collision of armed forces and perhaps the loss of life, I do this under protest and impelled by said force, yield my authority. Until such time that the government of the United States shall, upon facts being presented to it, undo the action of its representatives." So here she's saying she really wants to care for her people and not have anyone die as a consequence of this overthrow. But she was really under the assumption that the Hawaiian kingdom would be reestablished in her being queen. And so we have to recognize that this was the history, because this colonization history leads to things like some of the health disparities that we'll talk about today. And then unfortunately in 1898, we acknowledged that annexation occurred, and Hawaii became a US territory in 1900, and then finally entering statehood in 1959. And so while many people may think that this may be ancient history, as a Native Hawaiian kind of growing up in the islands, I recognize that my grandma was born in Hawaii as a US territory, and her grandma was born in Hawaii as the Hawaiian kingdom. So in the context and lens of our Native Hawaiian people, in my generation, in my family, this truly was not ancient history, as many of our ohana really remember, these days. And so in summary of this second section, the Kingdom of Hawaii, prior to its annexation, it was truly an internationally recognized sovereign nation, something that we oftentimes forget. So now, kind of going to do a deeper dive now, specifically on the health of our Pacific Islander communities. So we always have to think about kind of what was the health of our people prior to colonization. And while I must say with the caveat that this is kind of words from Captain Cook kind of depicted through a lens of kind of Western colonization, I do think that it is written legacy that he has read, that he has written, that we can now read to see kind of what was the kind of perceptions of the health back in those days. And he says that the Native Hawaiians, at least, were well made. They walked very gracefully, ran with agility, endured a great amount of fatigue. And this is due to their very active lifestyles. They were out in Lo'ikalo, doing a lot of agricultural work. They were out fishing. They had a rich cultural history of different activities, including things like forms of surfing as well. So they were very active people. In addition to that, they had the kahuna la'au, who were the medical healers in the kind of context of Hawaiian history. And these people, throughout the Pacific, these healers were so necessary for survival because they were truly the most isolated regions in the entire world. And these healers practiced holistic medicine, deeply rooted in nature and connected in spirituality. But that, unfortunately, alone was not able to combat what was to come, were the first, 100 or so years after Western contact. Some estimates of, and some of this is underestimates, but over 95% of our population was wiped out due to foreign diseases brought by Western contact. And this truly was devastation to our population of Native Hawaiians in our islands, with some estimates of less than 20 or 30,000 Native Hawaiians left by 1900, and a very small portion of that was of reproductive age. So I always talk about this because a lot of people will say, our populations are really small, we can't do statistics, we can't data disaggregate, but really we have to think about the colonization history and past, because the reason why we are so small today was not because we were not a thriving society back in early times, but truly because of some of the diseases that occurred throughout our history. And I must also say that this is not specific to Hawaii, right? This is throughout the Pacific, as colonization has happened. And this is a very nice Lancet paper that was published back in 2006, where Drs. Anderson, Kamaka, and Palafox were able to very nicely detail how the introduction of foreign diseases like the Native Hawaiians devastated many of these islands. But in addition to that, there was loss of civil rights, introduction of historical trauma, erasure of our identities, loss of culture and land. And these things together have led to things like the perpetual racial discrimination that many of our Pacific Islander community faces. And it's not only to the people, right? It's to the Aina as well, especially in the context of Oppenheimer kind of coming out right now and this past weekend. We have to think about how our Aina has been treated throughout colonization as well. So through the Cold War, the Marshall Islands specifically had over 7,000 equivalent Hiroshima bomb detonation. And this is just through testing of these atomic bombs. And our cousins in French Polynesia also had nuclear weapons testing as well. And so this had also important implications in terms of our health as well. Because as we know, with many decades of research, radioiodine fallout led to things like a number of different types of cancers that spiked after these nuclear bomb testings. Upon my review of the data, obviously the thyroid cancer data seems to be the most strong. And then this has led to things like radiation aversion as well. That has been led by multi-generational trauma throughout the Pacific due to what I believe is caused by nuclear bomb testing in part. And so this is data that my research group has focused on as a radiation oncology resident and trainee who wants to become a physician in radiation oncology. I've seen this firsthand, both in my ohana, but also throughout the patients that I've seen in clinic who are Pacific Islander. This is a study throughout the United States where we look across races and look at who is refusing potentially life-saving radiation therapy when recommended by a physician. And the Native Hawaiian and other Pacific Islander population actually has the highest rates of refusal of treatment. And I use the word refusal specifically because that is how it was encoded in the databases. But importantly, not only are these rates the highest, but they are even increasing in the most recent years, which suggests things like, the perpetuation of this multi-generational trauma, but also a lack of engagement within our Pacific Islander communities, specifically for oncology care. And then I just want to shout out to student Dr. Lau, who we recently, our group published, just this month or last month, a paper where we specifically disaggregate out Asians and Pacific Islanders. And what we find is, even when we look at specifically Japanese in comparison to other East Asian groups, because we wanted to look at, maybe Hiroshima bomb also had implications for refusal of radiation therapy treatments. We don't see the same effect within the Japanese community. So it seems to be a signal specifically related to Native Hawaiian and other Pacific Islanders, again, potentially related to the historical trauma from nuclear bomb testing throughout the Pacific. So moving on to other types of diseases, right? It's not just oncology, it's not just the treatments, it's a variety of different chronic diseases. So when we look at obesity as measured by BMI, as one type of measurement for correlating with obesity, according to the WHO data, when we line up all nearly 200 countries, the top 10 countries with the highest prevalence of high BMI above 30, these are all Pacific Islander nations, right? We think in the continent that United States actually has the highest rates of obesity, but many, many people do not recognize that all of these are actually Pacific Islander nations. And this is echoed through our Hawaiian Islands as well, where Native Hawaiians in our own indigenous lands have the highest rates of obesity. And this is not just the only chronic disease, obviously. Every single one of these chronic diseases here, as outlined by the Hawaii State Department of Health, actually are the highest among Native Hawaiians in our historical data. And that's led to things like Native Hawaiians in our own indigenous lands having the shortest lifespans among all race and ethnic groups, including the Asian disaggregated population. And so when we look at, even historical papers, looking at historical data from the 1950s into 2010s, we can truly see that in the pink line here on the bottom, Native Hawaiians, again, in our own indigenous lands have had the lowest life expectancy. And again, this is in the context that we were a thriving, nation prior to colonization. Again, as you'll hear in the themes that I'm talking about, this is not specific to Hawaii. This is throughout the Pacific, where you can see here, these are the ticks of the non-indigenous population average life expectancy, and compared to the indigenous populations in each of these respective Pacific Islands, we see up to 17-year life expectancy decreases compared to the non-indigenous populations. But it's not just at the end of life, truly from the very beginning of life, with Pacifica infant mortality rates, with low birth weight rates. These are 2 to 3 times higher specifically in the indigenous population. And these are really attributed to as we now recognized and have recognized among certain experts for a very long time, that Pacific Islander social determinants of health obviously are at play when we think about many of the poor health outcomes. And so this is data from Office of Hawaiian Affairs, just commenting on Native Hawaiians, for example. In our islands, our Kiki have the highest rates of high school dropout, e-cigarette use, suicide ideation. As adults, we're the most uninsured, impoverished, homeless, or incarcerated as well. And so in summary of this now third section, when we think about colonization, it's truly occurred throughout the Pacific, and that helps contextualize the lasting effects on Native Hawaiian and other Pacific Islander health. So now we're going to dive a little bit deeper now into Pacific Islander data, specifically in the context through structural racism. And while many of us on the call many of you on the call are very well attuned to mental health, behavioral health sort of topics, even more so than I. This is a paper I'd like to shout out my colleagues, Alana Egan, who's a clinical psychology doctoral student, and Leimomi Kanagusku, who is a family medicine physician here on Oahu. We published together kind of this commentary on the unhoused population across the United States. And this is a prime example of Pacific Islander erasure and indigenous erasure, because there was this publication in JAMA, which is a very prominent health journal, one that I respect very much so. But in this data, while Native Hawaiian and other Pacific Islanders compared to all the other racial categories as federally defined, the Pacific Islander group actually had the highest rates of, specifically in this adolescent population, of homelessness. And because of that, I was very surprised to see that there was not a single mention of that in the results from this research group. And so therefore, the three of us published in JAMA this commentary, really highlighting the importance of not only collecting disaggregated data, not only keeping the data disaggregated, but also reporting the significant health disparities, especially among the smaller indigenous populations. And so that leads to this conversation, right, of structural racism. This is a study by Dr. Bailey and colleagues published in The Lancet, really detailing quite nicely in my review and it taught me a lot about what structural racism in the context of data. And so what is structural racism? It's truly these discriminatory practices that have been perpetuated by, values, beliefs, and society's resources, and it's in different sectors, not just in healthcare, but in the housing sector, education sector, social justice system, and it's the way that society really perceives and sets up these different types of definitions that then leads to, again, these perpetuation of discriminatory values. And so when we think about it in the context of Native Hawaiian or the Pacific Islander health and our data disaggregated, we really have to think about the context of these definitions. So I always bring up U.S. Public Law 103-150, led by Senator Akaka in 1993. This was a really nice joint resolution for the Senate and House of Representatives that was on the 100th anniversary of the overthrow of the Hawaiian Kingdom. And it not only comments on the suppression of our sovereignty, tries to make amends with the Native Hawaiian community, but for me as a data scientist, specifically interested in data disaggregation, it's important because it defines who Native Hawaiians are for the first time, and it defines us as Aboriginal people who lived in our islands prior to Captain Cook's arrival in 1778. And I say that in 1993, this was important because this led to the most recent OMB terminology, race terminology, right? In 1997, that's when the Federal Registrar then disaggregated out Asian from Native Hawaiian or the Pacific Islanders. And for the first time in 1997, a quarter century ago, we then have these 5 official race categories. And as an aside, I learned very kind of late in my training. But the reason why we don't use the word Native Americans as an aside of what, in reference to American Indian and Alaska Native populations is because when we say Native Americans, many of us don't realize we're also including Native Hawaiians in that. And that's the same reason why, many people are confused of why do we say Native Hawaiian and other Pacific Islanders. It's not to be exclusionary. It's truly because of the way that the Native Hawaiian population is included in this United States Code, Title 25. But in general, I also like to just call us Pacific Islanders as one community, and especially in the context of data disaggregation from our Asian American populations. So what did that mean in terms of now having this definition? Well, this meant that after this public law got established in the Clinton administration, again led by Senator Akaka, this led to things like in the 2020 census, with context that the first sentence occurred in 1790. In the 2000 census was the first time where we then saw Native Hawaiian, Chamorro, Samoan, and other Pacific Islanders as a checkbox, which then we could identify that Pacific Islanders were actually the fastest growing population compared to other races in the country. Specifically, when we look at my field of oncology, so this is a very nice report that's published frequently from the University of Hawaii, Hawaii Tumor Registry, in collaboration with the University of Hawaii Cancer Center. As a very early trainee, looking at this book, I was very inspired, but also traumatized slightly that when I read through this, every single cancer section in this very large book of hundreds of pages, every single cancer said Native Hawaiians had the highest mortality. And while I was not shocked and traumatized, I was traumatized. I also appreciated this as there was recognition of our Pacific Islander communities in the data, and it really reflected the experiences of my ohana as well, having many of these types of cancers and again, dying from these cancers. And so you can imagine that when I entered this field then, and I started diving into the literature very early on, every single one of the papers I came across of aggregated Asian Americans and Pacific Islanders together, and every single one of these papers said that Pacific Islanders in this aggregated group had better survival compared to these other races. And that to me did not sit well because I've seen my ohana die from these cancers. And so it really inspired me to kind of dive deeper into this. That aside, those were individual publications, but what about, societies such as the American Association for Cancer Research, a society that I have served as associate member counsel for years on, and a society that I very much respect at a high degree. They also, in their health disparities report, aggregated together Pacific Islanders with Asian Americans, and then comment, and this is their quote, that they have the lowest overall cancer incidence and death. They also commented on how they have low COVID, hospitalization rates, and that to me didn't sit very well and was very concerning. And so this leads to, again, this conversation of data erasure as a form of structural racism. This was, published by Dr. Mori and Ninez Pons from UCLA Center for Health Policy Research, where they detail very beautifully the kind of contextualization of what structural racism does and how it truly masks the health disparities, specifically for the Native Hawaiian and other Pacific Islander population through colonization and settler colonialism practices. This is truly erasing a lot of our data, which then leads to gaps in our data that would otherwise inform public policy or federal funding. And so this is something that we truly need to recognize as members of the Native Hawaiian and other Pacific Islander community. And so that's why I've advocated, along with my colleagues out at Johns Hopkins, this was another kind of commentary in JAMA that we were able to publish, really kind of detailing why I personally don't use AA and HPI as a terminology. I will always write it out as AA and Pacific Islanders, for example, especially in the context of when we're not even talking about Pacific Islanders in that specific context, because I think it's very disingenuous to, that Native Hawaiian and other Pacific Islanders might take up 4 of the 6 letters, but then constitute like none of the data. And so I think we should call it what it is when we're talking about Asian American data. It's okay to just call it Asian American data and not call it Asian American, Native Hawaiian, and other Pacific Islander data, because that would only contribute to indigenous erasure. And so there's layers of complexity to this, right? So this is data from the most recent 2020 census where I've kind of crunched the numbers. And when we look at who we're talking about when we're talking about Pacific Islanders, we have to also recognize that we're a very multiracial group as Pacific Islanders, with the vast majority of Native Hawaiian of the Pacific Islanders being multiracial. And this is also something important to recognize in the context of what are the multiracial components, right? And this is something that I recognize growing up here in Hawaii, being privileged to go to Kamehameha schools, that not all of the multiracial Native Hawaiians are even Asian. So to categorize Pacific Islanders, I think with Asians, I think was a overstep of some of the folks who kind of kept some of these definitions early on, with kind of putting us as the other in terms of Pacific Islanders with Asian Americans. This is my opinion, because when I actually see, the vast, diversity of multiracial Pacific Islanders, and if you look at the data, actually most of them are white Pacific Islanders, and that's again just through being here in Hawaii, a very culturally diverse population, where it's not even Asian Pacific Islanders being the majority of multiracial Pacific Islanders. But in the context of data disaggregation and data in general, we have to think about how we're using Pacific Islander data. Is it NHPI alone, or is it multiracial NHPI? Because when we remove the multiracial NHPI, we may not be actually looking at the true majority of Pacific Islanders who exist in the United States today. And so a couple of problems that we talk about in this data disaggregation space, for example, the small sample problem. This is something as an editor, as a reviewer, something that I see pushback on sometimes through authors of why we can't include Native Hawaiian and other Pacific Islanders. Well, first of all, they might say, oh, the population is too small. We had to get rid of that and put them in other or aggregate together. Well, many researchers have actually found that you can aggregate over different types of spaces. So either spaces in time or spaces in geography, you can aggregate this. And this is a study from Dr. Andy Subika, who kind of looked at this with both the Pacific Islander population as well as our indigenous American Indian Alaska Native cousins, and showed that this is a technique that you could use to pull to include the right data. And then in another situation, some folks say the data doesn't exist. And this is a true example of a study that came out in the Lancet. This was life expectancy data by county and race and ethnicity from 2000 and 2019. Dr. Karen Pellegrin served as one of the reviewers on this study. And as a professor at the University of Hawaii Hilo, she actually looked at the data and was quite shocked that Asian American and Pacific Islanders were aggregated in one group. She advocated for the disaggregation, and they said at first the data doesn't exist. But this was, and the reason why this was important, because it showed that the life expectancy was actually higher among this aggregated group compared to the white population, and that didn't sit right with her. And I concurred with that. And so what she recommended was, well, you can think outside of the box. You have county level data and you have life expectancy data. So what she encouraged the authors to do, and which they did very, very nicely, was they actually were able to look at life expectancy in the context of the percent of Pacific Islander by county level data. And what they find here in this graph, and what they included in their actual publication in the Lancet, was you can see in the top left-hand corner of this box, you'll see that life expectancy was actually the highest among the counties with the lowest amount of Pacific Islander community population. And then vice versa, when we see the bottom right hand of the screen, the populations that actually had the highest amounts of Pacific Islanders, they actually had the lowest life expectancy. So this was just a great example, I think, that demonstrated how you can really think outside of the box with the data that you do have to still include the message of this data disaggregation. And so this was a commentary that we were invited to write in the Lancet with myself and Dr. Pellegrin. And so I can't also mentioned the impact of data omission on COVID. Early on in the pandemic, there was a lot of news coverage for Black and Hispanic individuals, as rightfully so, as they have a lot of health disparities of their own. But that led to a lot of members within our communities really not acknowledging or thinking that COVID could be something that we could die of. And this is something that even within my own ohana, I've had to see as I've had an uncle, he had a little bit of a cold, he went to the hospital, and he actually didn't make it out of the hospital as he died from COVID. And so this data omission then leads to kind of a lack of awareness within our communities. And so that is the true impact of data omission and a lack of data disaggregation. And so that's why, in order to combat structural racism through these things that have very important health implications, I always recommend we not only have to include the disaggregated data, we don't have to just disaggregate and keep it disaggregated while analyzing it, but we also have to report and spread to the general public this disaggregated data. And so in summary of this kind of fourth section, really Pacific Islanders have, as a race, have been defined since 1997. It's often aggregated with the Asian American population, which is heterogeneous in and of itself and is not a monolithic group that does, the Asian American community does face very heterogeneous health disparities. But when we combine the Native Hawaiian and other Pacific Islander group with the Asian American population, this is masking key disparities within the Pacific Islander community. And so now I'll kind of end on this topic specifically for Pacific Islanders. And I just want to start with, again, this COVID data. So this is data from a publication from the UCLA Center of Health Policy Research, led by Dr. Ninez Ponce. And what they were looking at was, first of all, how many states were early on in the pandemic were actually including disaggregated data from all of the states. And actually only 20 of those states were including Native Hawaiian and other Pacific Islander data in accordance with federal guidelines from a quarter century ago in 1997. And when they just looked at those 20 states, 18 of the 20 states actually saw that Native Hawaiian and other Pacific Islanders, when you disaggregate the data, actually had the highest rates of COVID-19 related deaths. And not just in COVID, but obviously in my field of oncology, we see this. So this is a study published in JAMA Network Open with my colleagues at the University of Hawaii Cancer Center, Dr. Liu and Hernandez. And what we find is, for example, when we have a population of patients who have non-invasive breast cancer who get treated with the appropriate treatments, what is the probability of a population having a second invasive breast cancer? And that's really an important question for us clinically, because we want to truly avoid overtreating patients who are maybe at lower risk, but then prevent undertreating patients who might be at higher risk. And what our data found was specifically in our own native lands, the Native Hawaiian and other Native Hawaiian population, these women had the highest rates of ipsilateral and contralateral invasive breast cancer. But we can also look at this. This is another study on a national scale now, where we're looking at, this is a study from Dr. D and Dr. Fumiko Chino out at Memorial Sloan Kettering. These are my colleagues, where we published in JCO Oncology Practice, looking at, how do we disaggregate the single line that's classically, again, put in as this AA NHPI group. And what we did was, this is a Kaplan-Meier curve looking at overall survival for patients with breast cancer over the course of 15 years, where we're disaggregating East Asian, South Asian, and Southeast Asian, because in our data, these groups often will disaggregate together. But compared to the Native Hawaiian and other Pacific Islander group, this group is truly what disaggregates out in terms of overall survival, which is something that we've been talking about this whole time. And this is significantly different. But we look at things like, even within this population, the time to treatment. So we found, again, in that same kind of data disaggregation situation, that Native Hawaiian and other Pacific Islanders, compared to these ethnogeographically disaggregated Asian American groups, it's really the Pacific Islanders that have longer times to things like surgery to radiation intervals, which has impacts on clinical outcomes, not just in breast cancer. But this is another study that I'm very proud to have published with many of my Pacific Islander collaborators under the mentorship of Dr. Archie Pullum and Elizabeth Kidd at Stanford. We find that Native Hawaiian and the Pacific Islanders have the lowest rates of things like brachytherapy treatment when it's recommended by a physician. In other data in cancer, this is data from my collaborators, Doctors Xing and Vo at the National Cancer Institute, where we're looking at even specifically HPV-associated cancers, a type of cancer that's very important in the context of Micronesia, for example, with a lot of betel nut-induced oral cavity cancers, as well as other HPV-associated cancers. But when we look at these HPV-associated cancers specifically, we find that Native Hawaiian and other Pacific Islander men have not only higher incidence, but increasing incidence over the course of time from the 1990s, specifically compared to these other East, South, Southeast Asian groups. And this informs things like targeted interventions that might kind of focus on cancer screening, HPV cancer screening, and prevention as well, specifically among our population. In other studies that we've published in JAMA Network Open, looking at comorbidity burden, we also find that Pacific Islanders have a higher comorbidity burden. So that's, as we've discussed in previous slides, it's all of those different types of diseases that these individuals have, not just a cancer. And that's crucially important in the clinic, because when we think about clinical trials, which inform future practices of how do we take care of our patients with cancer, for example, this is a study that's being conducted by my lab, who are predominantly Native Hawaiian, Chamorro, Yapese, et cetera. So they're Pacific Islanders. And what we find is that Native Hawaiian and other Pacific Islanders have very low inclusion and reporting in clinical trials across the country. And so, again, it's important in the context of comorbidity burden, if that's an exclusion criteria that then is informing why these clinical trials are not including these patients. It's something to recognize, and we can only recognize that through data disaggregation. And then another thing is obviously survival. We've talked about this. Poor survival across many of these different types of cancer, specifically only seen among the Pacific Islander population, as opposed to a lot of these other Asian groups when disaggregated. And then most recently, this is very recent data published by my colleagues, again, in collaboration with the National Cancer Institute. Again, no surprise, both men and women who are Native Hawaiian and other Pacific Islanders have high mortality compared to Asians. But the importance of this study that was recently published in the Journal of National Cancer Institute was that for the first time in the history, we're able to demonstrate that historically, it's only been Black individuals who have had the highest mortality across all racial groups, but all of those studies previously had aggregated together Asians and Pacific Islanders. So this recent study that just came out in April was a monumental step forward, led by the NCI, because it demonstrated for the first time that it wasn't Black, it was actually Native Hawaiian and other Pacific Islander populations when disaggregated that have the highest mortality among individuals who are aged 20 to 49. And that's very relevant to my own lived experiences, as many of the lived experiences of members of our community as well. And then kind of this final point of data disaggregation, it truly is important within how we see the physician workforce as well. As in Hawaii in general, there's 20+% of the population that's Native Hawaiian, for example, but less than 4% is of the physician workforce is Native Hawaiian. So there's this true discrepancy, and that is really under-acknowledged nationally, where the data has largely been improperly disaggregated. And so this is a study that I did with my mentor, Dr. DeVille, out at Hopkins, where we look at both medical students, residents, and faculty members when we disaggregate the data. And we find that Pacific Islanders not only are currently half of what we would expect compared to the US Census, as opposed to the 3 times representation of the Asian American community, but this rate of the Pacific Islander representation is only decreasing. And this was a study that we published in JAMA Open Network. And so this is important in terms of the physician workforce being reflective of the population at large, especially for the Pacific Islander community, because we know from Drs. Kamaka, Paula Fox, Koholukula, their previous studies on the Pacific Islander population that we can improve healthcare outcomes through things like medication adherence and perceived patient quality of care, through patient racially concordant care. So it is a truly important issue, and we can see that through, again, data disaggregation when we're looking at the physician workforce. And kind of wrapping up here, the importance and relevance of this topic of Pacific Islander health, not just here in Hawaii, not just in the US affiliated Pacific Islander regions, but also on the continent at large. It's a very important issue as we're having, for the first time, seeing the 2020 census, acknowledging that there are more Native Hawaiians now living on the continent than in our own indigenous lands due to the diaspora, related to low wages in the islands, high cost of living, and that's led to things like Pacific Islanders and Native Hawaiians both leaving Hawaii. And so truly Pacific Islander health issues are becoming issues on the continent nationally as well. And so kind of wrapping up, keys for advancement for Pacific Islander research, we have to include Pacific Islander voices, something that I truly tried to practice within my own research group that, again, are predominantly Native Hawaiian and other Pacific Islanders. We have to continue interdisciplinary collaboration among our Pacific Islander groups, but also we rely, I will say we rely on allyship within our non-Pacific Islander researchers, because together we're able to get the data, publish the data, and then make informed practice changes and public policy changes in accordance to the disaggregated data. So in summary of this final point, Pacific Islander data disaggregation practices, we've now been able to unmask key health statistics that have been truly hidden for a quarter century since the 1997 Office of Management and Budget update of race definitions. And so these final slides here, I've talked a lot about doom and gloom of the Pacific Islander population, but I want to highlight some of the key advancements that are being made, right? So I mentioned AACR previously aggregated together the data in the previous cancer disparities report, but in their most recent report, we see Auntie Native Hawaiian right up here on the cover, first patient right on the cover. We see that she's a proud Native Hawaiian. She wants Hawaiians to live and learn more about cancer. So I really respect organizations like this that include data disaggregation practices and acknowledge how we can advance this field moving forward, and including the ACS journals as well, where now these are the most cited of the cancer journals. And now they're putting asterisks in their data now when they're citing data that are aggregated with Asian and Pacific Islanders. Now that they're making caveats of citing some of our data, saying, hey, we have to take into the caveat that these are maybe not reflective of the Pacific Islander population as they are aggregated together. And finally, in terms of the physician workforce of Native Hawaiian and other Pacific Islanders, I want to just give a shout out to my Kamehameha School's Kapalama campus class of 2008. We have 11 of us who have entered the physician workforce. So even though the representation is low, I do think that there is a path forward, both with my lab, both with my classmates from high school. I think that together we're making a difference in terms of the representation of the Native Hawaiian and other Pacific Islander physician workforce. And this was even recognized in our recent news with Dr. Brittany Sato recently graduating with her MD and PhD from JABSOM, and now is going to be entering residency. And so with that, I'm just going to make some 3 final conclusions. Number 1, Pacific Islanders were culturally and historically distinct from Asian Americans. Number 2, aggregating or omitting Pacific Islander data is a form of structural racism that we must combat. And then finally, Pacific Islanders should always be included, disaggregated, and reported in studies. I'd like to mahalo my many mentors and collaborators from Stanford, University of Hawaii, UNLV, Hopkins, NIH, as well as the many Pacific Islander members and Pacific Islander allies in my lab, as well as my funders at Stanford. And with that, I would like to mahalo you all also for attending this webinar today through the Ohana Center of Excellence and the Hawaii State Department of Health. I really appreciate everyone being here today to learn a little bit more about why this is so important. Mahalo.
Well, a big mahalo to Kekoa, and thank you for that very informative talk and just very inspiring as well. And I think we had one question actually. I don't know if you saw that, Dr. Taparra.
Oh yeah. Now we'll take some time for questions. Let me pull them up. Q&A, got it. All right. Oh, on questions. So, okay. So I will read the question / comment. Recent meeting with USVA office during their visit to Guam. We were informed that veteran suicide in the island is not in their radar because CDC doesn't recognize numbers to be in high enough to include for national data set. Less than 10, which is as you rightly point out, is a common practice among the epidemiology those who practice epidemiology research. That is a common statistical kind of threshold that they use is less than 10, then they'll suppress the data. So what they do not recognize is that there are gaps in the data collection, and reporting that the numbers are that the federal government see the numbers the federal government see is inaccurate depiction of what's truly happening in our homes. So this is also true for substance use. Definitely agree with that. Just going to continue to the question. What can we collectively do as a region so that we can advocate for inclusion and representation so that we can accurately disaggregate based on Pacific Islander comparison, ethnicities in the country? So mahalo for that question. I think it's you touch on so many important points in terms of, again, there are, I don't want to say gatekeepers of the data, but then there are, those who are classically trained in these epidemiological practices that focus primarily on very large data sets. And in their practice, they oftentimes will suppress numbers less than 10. As I kind of, to address one thing, just in terms of the epidemiology, as I've pointed out, one of the practices that we can think about effectively in that one paper from Dr. Andy Subika and colleagues was that, pooling data over the course of both time and geography is something that we can think about, right? So sure, if given, an annualized rate of less than 10 cases, you might exclude that data. But what about when you pool it across time and space? So maybe not even just in like one island, but multiple islands, or let's say even like Micronesia as a whole. What happens when we pool across time and space? That's one way to then get the numbers above 10. And then you can do statistics to kind of find the incidence or prevalence for the community, especially with things like, these very important issues that you're talking about in terms of suicide, as well as, these other issues. But then in terms of the second component of the question of what can we collectively do? So that's from a research standpoint, but what can we collectively do? I think, I can just speak for myself, first of all, being here, engaging in these sorts of organizations with Hawaii State Department of Health or the Ohana Center of Excellence, as well as advocating for or with your state or local kind of representatives. I think that that's incredibly important, as public policy often informs kind of data practices, and we can all work together. So I think having that voice, for me personally, I use platforms like Twitter and social media in order to get out my kind of message on some of these issues. And then finally, I think collaboration. I'm always open to, for myself, kind of collaborating with members, especially on the ground in the community, who are facing these issues, so that I can amplify their voices, as I want to also use this position and platform that I've been, given, so that I can make sure that I'm making sure, so I can make sure that the appropriate voices are being heard, because I do agree with all of your comments that those are important issues that we have to be addressing moving forward. But mahalo for that question. So I think that was the one question in the chat. Okay, so one more question. in Hawaii and the US, has there been any discussion of disaggregation of Native Hawaiians from other Pacific Islander groups based on the different traumas faced by these different groups? That is an excellent question. For similar reasons to what we just discussed with that previous question, while I do agree, acknowledging the differences of the different traumas, also cultural, traditional practices of the different Pacific Islands and their regions, while they are different from a data perspective, because Pacific Islanders are such a small group, oftentimes kind of getting the numbers above that 10 threshold is one of the ways that we do that, is focusing on community, focusing on who we are as a collective Pacific Islander race. Again, deeply rooted in this oceanic voyaging heritage, which with shared and similar colonization history, past and trauma. I like to focus on kind of the collective community of our group. So in my data practices, I oftentimes will keep us together so that we can communicate the strongest message that we can, again, which is to include NHPI as a group, as a whole. But to your point, though, there are often conversations to disaggregate these different islands and islander groups. However, the data oftentimes is the limitation, and so we can circumvent that with the pooling of the right data to still get across the same message, as long as, in my mind, as long as the kind of directionality of the data is still going into the same direction. I think together our voices are heard better collectively. But mahalo for that question. I do see that we're up at the hour, so I definitely want to mahalo everyone for being here, and for the Hawaii Department of Health and Ohana Center of Excellence for allowing me the opportunity to be here today.
Mahalo, Kekoa, and mahalo to all of you for joining us here today. And if you wouldn't mind, if you could please complete the survey that's in the chat, we'd really appreciate it. And again, that information is used for us to actually, as part of this, to help gather data, and so that we can better serve the Asian American, Native Hawaiian, and Pacific Islander communities that we're serving. So thank you again, and I hope you all have a great rest of your day. Mahalo.